And in the last session, we have a very interesting topic that was very rarely discussed in the meeting. Uh, that is the management of myocarditis and pericarditis. Because these two things is not having a single disease, it is a manifestation of so many internal disease process, but mostly because of the some infections, some toxins, some drugs, they leads to heart failure sort of symptoms, myocarditis. Sometimes rheumatic also is very known for causing the myocarditis and endocarditis. So, and similarly, the pericarditis is also very prone for involvement as a multi serositis condition where there are various serious tissue, serious layer of the body gets involved, and the myocardium is one of them, like synovial sheath, lungs, membrane, pleura. So the pericardium is also a part that gets primarily involved, leading to different clinical situations like simple pericarditis that may resolve on its own or may lead to some serious condition, constriction of the pericardium, and itself a different kind of cardiac syndrome. So today we have a very learned speaker who doesn't require any introduction, Professor Vikash Agrawal. He is an HOD of IMS BHU. He is the right person to deliver the lecture on such a difficult topic, and that will be very useful for all the specialists as well as for the physicians attending this conference. Thank you, sir, Dr. Vikas.
Thank you, sir, for this nice introduction. And first of all, I'd like to thank Dr. Alok for inviting me, and congratulations to Dr. Alok for having this 11th edition of his wonderful conference every year. So, what I'll be talking about is the ESC guidelines for the management of myocarditis and pericarditis. And these guidelines have been recently published, maybe a month back, and this is the first time that they have this comprehensive guidelines for the management of pericarditis and myocarditis. It's a very exhaustive document that we have, and I just try to pinpoint some of the important points that they have included in these guidelines. So the most important thing about these guidelines are that they have introduced this new term, that they have terminology for this syndrome of myocarditis and pericarditis, and they have this as inflammatory myopericardial syndrome, IMPS. So this is basically, now that they have introduced this term, this includes both myocarditis and pericarditis, and the rationale they have given behind including this term is that myocarditis and pericarditis frequently co-occur because they are in anatomic continuity, and they have a shared pathophysiology, and most of the times we require holistic treatment because of the overlap that there is, holistic treatment, and the etiology is also common most of the times for both myocarditis and pericarditis. And this is the central illustration. This is an illustration where they have basically given a summary of the guidelines basically. So I'll just go forward. They have included this term that for the clinical diagnosis of myocarditis, they have introduced that there is a paradigm change, and this paradigm change has been brought about by the role of imaging. Because of the use of cardiac MR imaging that has evolved over the years and have increased over the years, now that we have a more robust diagnosis of myocarditis especially, and that has led to the more definitive diagnosis of myocarditis and possibly for more pericarditis, and also better diagnosis and better treatment. So this paradigm change is because of the increase in imaging that has over the years, especially for cardiac magnetic resonance imaging. The terminology included in these guidelines for the different syndromes, IMPS, it could be myopericarditis, which includes predominant pericarditis, or perimyocarditis, which is predominant myocarditis. Acute myocarditis is basically acute onset of symptoms, duration of symptoms of less than 4 weeks, and it can be termed as fulminant if the acute onset at hemodynamic unstable patients requiring inotropes and mechanical circulatory support. Complicated myocarditis due to different complications. The new terms that they have basically introduced are recurrent myocarditis, remission without residuals, and remission with residuals. So recurrent myocarditis is new symptoms or disease activity after clinical remission, and remission without residuals is basically regression or absence of symptoms, normalization of ECG biomarkers and imaging of abnormalities. And remission with residuals is once there are no symptoms but persistent of abnormalities on ECG biomarkers or imaging. So these are the three new terms that they have introduced in these guidelines. The stages of inflammatory myopericardial syndrome: acute is less than 1 month, subacute is 1 to 3 months, and more than 3 months they have termed as chronic stage. They have given different, according to these the stages, they have basically included etiology also here. So it could be infectious or non-infectious causes. Basically this includes autoimmune and an overlap between the two, where both infectious and non-infectious components could be there. Then there's an important role of genetic susceptibility that they have introduced in these guidelines, and these are the patients who have recurrent episodes of pericarditis or myocarditis. So genetics is important in diagnosing these patients because they are more prone to recurrent attacks of pericarditis. The spectrum of myocarditis presentations and outcomes: the patient could be oligosymptomatic. Chest pain could be the initial presentation. Initial presentation could be heart failure, or in fulminant cases, or aborted SCD. And arrhythmias could also be the first presentation in patients of myocarditis. So this is basically a spectrum of presentations that these patients of myocarditis can present, and this could lead to dilated cardiomyopathy, remission, or different presentations. Coming to the diagnostic criteria and classification, basically what they have introduced here is the three-tier system. Three-tier system is basically definite, possible, and unlikely or rejected diagnosis. And here basically what you look at is the clinical presentation, the clinical symptoms if they mimic to have these myocarditis or pericarditis. This should be proven by different investigations. And investigations could be ECG, biomarkers, or imaging. But for a definite diagnosis of myocarditis, you require clinical presentation, and CMR or EMB proven diagnosis is important to prove a patient of definite myocarditis. For pericarditis, clinical presentation with one additional criteria. Additional criteria could be pericardial rub, PR depression, or widespread ST depression, CRP elevation, or new worsening pericardial effusion, or pericardial edema on CMR findings. So these could lead to definite diagnosis of pericarditis. So the importance of diagnosis of myocarditis: to make a definitive diagnosis, it should be CMR or EMB, endomyocardial biopsy proven, to give a definite diagnosis. And the CMR, basically what they have introduced in the diagnostic criteria is the Lake-Lewis criteria. This is basically a multimodal CMR approach where you look at the T2 based criteria, the T1 based criteria, and the supporting criteria. But the most robust criteria is the T2 proven criteria. Once 2 out of the 2 updated LLC criteria are present, you can label that patient as a definite myocarditis. So CMR is the most important investigation for diagnosing myocarditis. Then the histopathological criteria for myocarditis: this is the EMB proven endomyocardial biopsy, and basically you look for myocyte necrosis on histopathology and the type of inflammatory cells to label the myocarditis as different, whether it is lymphocytic, resolved lymphocytic, eosinophilic, or giant cell myocarditis, and also for sarcoidosis. Then they have introduced this clinical diagnosis of myocarditis and pericarditis with the use of red flags. These are different host of symptoms for pericarditis and myocarditis, which also includes serological and imaging biomarkers. So all these biomarkers and imaging symptoms and signs are important to basically make for diagnosis of myocarditis or pericarditis, and for the diagnosis of inflammatory IMPS. All these patients have to be risk stratified. Once you made a diagnosis, the risk stratification basically depends upon the clinical features and the imaging criteria. So imaging criteria for myocarditis and for pericarditis are different. for high risk and intermediate risk, the importance of clinical stratification or clinical risk stratification is for the management of these patients, because once you have an intermediate and high risk patient, the management is different as opposed to the low risk patient. So imaging criteria and clinical symptoms are important to stratify these patients into high risk, intermediate risk, or low risk for myocarditis and pericarditis both. Endomyocardial biopsy they have given that is more important for high risk patients. So once a patient is at high risk, once you have diagnosed myocarditis which is high risk, all patients of high risk myocarditis should undergo endomyocardial biopsy, and the reason they have given is because of the treatment of different forms of myocarditis is different, and these patients require aggressive and more important treatment. So endomyocardial biopsy is important for all high risk patients, and also in some intermediate risk patients where the knowledge of the histological subtype and the identification of a possible viral etiology are important for targeted therapies. So intermediate and high risk patients, especially for high risk patients, endomyocardial biopsy is very important. But in the guidelines they have mentioned that you should not wait for treatment initiation. The treatment should be started, and once the patient you think can undergo endomyocardial biopsy, this should be done, and then the treatment altered once in an admitted patient for after the endomyocardial biopsy results are available. They have given different diagnostic algorithms according to the type of presentation and where the patient presents: inpatient myocarditis, outpatient myocarditis. And the important thing here is that all patients, whether it is inpatients or outpatients, they have to be risk stratified into low, intermediate, and high risk. And endomyocardial biopsy is important for inpatient patients, which is a class 1 indication, along with the cardiovascular magnetic resonance. So CMR you have to do in all patients. Endomyocardial biopsy in high risk and intermediate risk patients is important for management. For patients who present with arrhythmia, the only presentation is arrhythmia. These patients have also to be managed, these patients have to be risk stratified into high risk versus non-high risk. And once you look at the algorithm in the down part, these patients who present with arrhythmia, a repeat CMR should be done in these patients at 6 months, and the utility they have given to do a repeat CMR at 6 months is to rule out whether they still have active myocarditis or not. Once you have ruled out that these patients do not have active myocarditis, these patients can undergo secondary prevention ICD implantation. Not and ICD implantation during active myocarditis is not recommended. So clearing whether the active myocarditis has gone away, these patients can undergo ICD implantation, which is a class 2A indication. For patients who present with arrhythmia for the duration of period of 3 to 6 months, who present with arrhythmia, a wearable cardiac defibrillator as a bridge to recovery can be considered in these patients before you risk stratify these patients after 6 months. And patients who have additional risk factors, whether they have NSVT, extensive LGE, unexplained syncope, positive PVS, reduced LV ejection fraction, and genetically proven myocarditis, these are the patients who should go an implantation of an ICD, and this is where the role of ICD comes in. For the patient of pericarditis, triage is important, and basically depends upon the ECG, transthoracic echo, X-ray, routine blood investigation, CRP, and troponin. And these patients can also be divided into low risk, intermediate risk, and high risk. Pericarditis patients who have signs and symptoms of cardiac tamponade, fever, effusive constrictive pericarditis, failure of NSAID therapy, and incessant pericarditis, and the imaging criteria of large pericardial effusion, cardiac tamponade, or extensive LGE on CMR are considered to be high risk patients, and these patients require admission, etiology search, and aggressive anti-inflammatory therapy should be initiated in these group of patients. For cardiac tamponade, they have given a risk score of patients who should immediately go undergo pericardiocentesis, and this is basically a risk score in a tabulated form. When the risk score, cumulative score is more than 6 or equal to 6, these patients should go a pericardiocentesis. Otherwise, the pericardiocentesis can be postponed. For patients of constriction, they have basically said about the anti-inflammatory therapy for 3 to 6 months, and if they respond to that, then they could be followed, and if they develop presence of constriction, pericardiectomy is a class 1 indication in this group of patients. Regarding interventional therapy, pericardiocentesis is recommended for cardiac tamponade, suspected bacterial or neoplastic pericarditis, symptomatic moderate to large pericardial effusion despite medical therapy. And surgical pericardial drainage is recommended when percutaneous pericardiocentesis is not feasible or with purulent pericardial effusion. Surgical pleuropericardial window is recommended in patients with relapsing pericardial effusion despite medical therapy. How do you follow up these patients? All patients of myocarditis should be followed up within 6 months with clinical assessment, ECG, TTE, CMR. So repeat CMR should be done at 6 months in all these patients once you have diagnosed CMR. And these patients should be followed up for 12 months to 12 to 24 months. For complicated myocarditis or incessant or recurrent pericarditis, a longer time follow-up, maybe for 2 years or even more than that, should be done in these patients, because these patients still remain at risk to develop arrhythmias or other complications. Recommendations regarding medical therapy: NSAIDs together with proton pump inhibition should be considered in patients with myocarditis associated symptoms of pericarditis to reduce symptoms. So NSAIDs is class 2A. Colchicine should be considered in patients with myopericarditis to reduce recurrences. So now they have added colchicine in all patients of pericarditis. You can give colchicine. This was not there in the previous guidelines, but it has been shown that adding colchicine on top of NSAIDs reduces the recurrence of events and can be given in these patients. Management of heart failure according to guidelines: heart failure therapy should be given in myocarditis for at least 6 months upon complete LV functional recovery to stabilize LV function. Beta blockers for prevention of arrhythmias with a continuation for at least 6 months is a class 2A indication. For immunosuppressive therapy, corticosteroids should be considered in patients with fulminant non-infection forms of myocarditis to stabilize the patients, and corticosteroids may be considered in patients with acute myocarditis with impaired LV ejection fraction if refractory to standard heart failure therapy to stabilize patients. Routine use of immunosuppressive therapy is not recommended in acute myocarditis. This is the medical therapy for pericarditis. So basically start with NSAIDs, colchicine for 3 to 6 months. NSAIDs could be tapered after 2 to 3 months. You don't need to taper colchicine, and then if they respond to colchicine and NSAIDs, there are patients who do not respond to this kind or are recurrent or incessant. The true drugs they have given is anti-interleukin 1 agents like anakinra or rilonacept, which can be given in these patients. Somebody who can tolerate none of these drugs, corticosteroids can be given only in those group of patients. Regarding just about stages of tuberculous pericarditis, they have given this staging of tuberculous pericarditis. Stage 1 is dry, stage 2 is effusive, stage 3 is effusive constrictive, and stage 4 is constrictive pericarditis or pericardial constriction. The treatment for tuberculous pericarditis is basically diagnostic pericardiocentesis is recommended in all patients with suspected tuberculous pericarditis when diagnosis is not confirmed by non-invasive tests. Empirical antituberculous chemotherapy is recommended in patients living in endemic areas with exudative pericardial effusion after excluding other causes. So you don't have to make a confirmed diagnosis of tuberculous pericarditis. If you get on pericardiocentesis, you get a exudative pericardial effusion, you can start empirical antitubercular therapy. Standard antitubercular multi-drug therapy they have recommended only for 6 months and not more than that. Pericardiectomy is recommended in patients with tubercular pericarditis if the condition is not improving or is deteriorating after 4 to 8 weeks of antituberculous therapy. So pericardiectomy only after 4 to 8 weeks of anti-TB treatment. Diagnosis and management of tuberculous pericarditis and effusion in non-endemic areas, a pericardial biopsy may be considered. Empirical antituberculous treatment is not recommended in patients living in non-endemic areas. So finally, this is my conclusion slide. What they have told that it's a collective involvement of all the clinical cardiologists, pathologists, interventional cardiologists, cardiothoracic surgeon, psychologist, and electrophysiologist, cardiac intensive care specialist, and all these have to be involved in this multidisciplinary team for the management of IMPS. Thank you.
Very lucid and perfect talk by Dr. Vikash. If any question or suggestion, please ask. one more question is allowed. Only one question is allowed. We are getting late, so one question is allowed.
In our scenario, which etiology you find to be most responsible for myocarditis or pericarditis, and whether we didn't left anything except supportive therapy and steroid use, IV steroid use. So how is IV steroid is still useful? You have indicated at class 2A indication.
Yeah, for pericarditis, for mostly once you're talking about pericarditis, I think tuberculosis is a very important part in our which I think these guidelines, they have a section on tuberculous pericarditis, but it's more of different causes, whether it is neoplastic, whether it is radiation, whether it is post-infective. But once we're talking about tuberculous pericarditis, steroid, they have said ki you should give in all patients once you are starting anti-tubercular treatment in that, and the rationale they have given is that it decreases the incidence of constrictive pericarditis, development of constriction. Other treatment they have recommended for not development of, they have even given injection of intrapericardial urokinase can help to inhibit development of strands and fibrinous strands, and all these could be the methods so that's why they have given this recommendation that wait for 4 to 8 weeks and treat these patients aggressively so that they do not develop constrictive pericarditis or constriction in 4 to 8 weeks. Once they develop 4 to 8 weeks constriction, because anti-tubercular therapy also inhibits development of constriction. Once you start this treatment early, most of the patient may not develop constriction. So once they develop constriction, I think pericardectomy, this again goes into high risk category, and you have to do a pericardectomy in all these patients. Regarding myocarditis, I think viral is the most common etiology that we talk about, but they have given a lot of stress on genetics and because genetics, they have said that people who have genetic predisposition, they have recurrent myocarditis, and that is a bad component because these are the patients who don't fare well in the long term. Once you have viral myocarditis, maybe 2 to 3 months they require completely after a period of rest. Regarding rest, and they said that during acute treatment, all patients should be advised complete bed rest and complete rest during the myocarditis time.
What about chemo?
What about? Chemo.
Dengue.
Yeah, dengue-induced myocarditis, I think there was a section on coronavirus-induced myocarditis also, but again, the treatment-wise, they have, it's the same as all forms of viral myocarditis. Complicated viral, I have not taken this specific myocarditis where there is a whole section of specific therapies that you can give in different forms of myocarditis. So steroids, high dose steroids, immunosuppressive therapies, they all have a role in different forms of myocarditis. Even fulminant myocarditis, you have to be very aggressive with high dose steroids and immunosuppressive therapies if they are not, but that is a whole different section, so I have not included.
Okay, Dr. Vikash, for a very extensive talk, and you all aware the message, if you have a very thorough history of the patient who has presented with the fulminant myocarditis or pericarditis, history is very, very important, and you have to decide whether it is a myopericarditis is a part of the systemic disease or it is a separate disease. Once you decide it, then you have to treat the fulminant hepatitis, fulminant myocarditis with a very strong agent with the steroids, but be very cautious. Steroid itself can lead to myocarditis. That is very important. So the dose of steroids should be very, very limited, and it should be on your clinical response. There is no hard and fast dose that is recommended in any recommendation, but be aware about that. The high dose of toxin can itself lead to myocarditis. Another important issue, once the patient is having a separate identity of myocarditis, is not related to the systemic part, systemic inflammation, then definitely the question arises after remission phase, how potential risk is for the recurrence and what is the risk of the arrhythmia. As Dr. Vikas has told, that how you can go for the screening for the arrhythmia and require the specific anti-arrhythmic therapy, and that is very important, as today we have MRI, or at least you can have a signal averaging ECG potential recording that is a precursor of having the malignant arrhythmia in the future of the post myocarditis patients. Another important thing is if you have a planning for the recurrence and the patient requires the myocardial biopsy to confirm the diagnosis, to pinpoint the diagnosis, particularly chronic inflammatory glomerular myocarditis like sarcoidosis, amyloidosis, myocarditis, that involves also the myocardium and that may require sometimes the myocardial biopsy that can predict the specific agent to treat this into, but there is a very specific time. You cannot do it a myocardial biopsy when the patient is in a fulminant condition. There should be some time like clinical remission, that is a safe time to get the myocardial biopsy that will give you the final result, and that result can have a very direct hitting of the cause of the myocarditis, and that definitely that will help in the patient. So this is a very learned speaker, very thanks to Dr. Vikash. Now the next